Thanks, Mark. Really appreciate the kind introduction. This is one of my first trips back to DC to speak. I'm not going to have slides. It's going to be hopefully, I think it's going to, we talked, it'll be a relatively low-key panel. I finished at CMS September 15th and got in my car September 16th and drove down to North Carolina and started in this job October 1st. And our kids are settled in and doing well. I used to kid that CMS is like dog years, so the 7 years felt like 14. But I've now, in North Carolina, I've only been there 2 months, and it feels like 14 months. So I decided maybe the problem is me. I want to thank all of you for being here. I see a lot of faces I've known through different periods of career. A lot of people I've learned from in the audience, and see Sherry Ling, who was our Deputy Chief Medical Officer at CMS, and I met my first day there. Great geriatrician. I'll talk a little bit from a practicing physician perspective. I will tell some personal stories and then talk a bit about Blue Cross North Carolina as well. Actually next week, December 5th, interestingly the same day I officially become CEO, will be 10 years since my father passed away. He had cancer for about 7.5 years before he passed away. He was a Medicare beneficiary. I think, as probably is true for many of you, some challenging times managing his care, even with incredibly well-meaning providers and care teams, including a time where my mother called me in tears, had to fly out to Indiana where they were, talk to his hospital medicine physician about the fact that he was in hospice and he really wanted to die at home, despite his potassium and blood pressure at the time. And once again, these are not personal faults. It's systems and care teams and education and training, and I think a lot of the things we'll talk about today, and a real opportunity for caring for people with serious illness. So broader than just hospice and palliative care, but serious illness care. If you think about serious illness care, at the end of the day, I think it comes back to patient and family-centered care. This is a prelude. We've got some folks from Blue Cross North Carolina. You're going to hear this in 2 weeks. I'm going to talk about how I want us to care for every member, every customer, like they're our family. Full stop. I think if we do that well, we'll be a successful company. We'll succeed on our mission of healthier people in North Carolina, and I think we can deliver higher quality care, more patient-centered care, or portion-centered care, by that as sort of our North Star, if you will. A lot of details to follow that, which we'll talk about. A couple tenets just to call out. Training and education. My month as a resident in the pediatric ICU, we had 11 children die in 30 days. At the time, I didn't realize how uncommon that was. I will tell you, I wasn't prepared for that. And I think there's a big opportunity for interdisciplinary training and education across the clinical spectrum, social work, et cetera. 2, just briefly on alternative payment models. I don't think we've fully delivered on this yet, but I fundamentally believe as we move to alternative payment models where providers are accountable for quality and total cost of care, providers and clinicians and care teams over time, and they're at different stages right now is my hypothesis, will learn that serious illness care is critical, and they need to do it well to be successful, and of course they need to do it well because it's the right outcome for patients and families. From my time at CMS, I do think paying for advanced care planning was a meaningful step. It's certainly one step in a journey. I will tell you in North Carolina, we are also paying for advanced care planning from a commercial perspective. I think the CMS Innovation Center Medicare choices, none of the CMMI models, I got asked on a panel yesterday, you'll appreciate this, how many of the CMMI models were exactly the way you wanted them? And I was like, 0. So more work to do there, but I think the idea of delivering hospice and palliative care services concurrent with so-called curative care is a step in the right direction. Comprehensive Primary Care Plus, which I think we'll build on in North Carolina, so true comprehensive primary care that cares for people and families across their lifespan. A stat on North Carolina, we're about $10 billion health insurance company, but more importantly, we insure the majority of North Carolinians, and we insure many of them literally from birth until death. That is a huge opportunity for how you think about health trajectories and caring for people and families and investments that have long-term trajectories. I think I was at CTAC yesterday, and I know many of you in the room have developed serious illness models, including, like, when you go back to DC, you start using acronyms again, including ones that have gone to PTAC, the position, you can't remember what the acronyms mean anymore. But I think there's, I said this yesterday on a panel, but would want to say it here. I think we need to do more in serious illness payment models. So we can't just say we'll solve it by ACOs or comprehensive primary care. There's also got to be very specific payment models focused on serious illness care. Dual eligible demonstrations, I think we'll hear a little bit more about in some of the other work, so I won't steal anyone else's thunder. Just to briefly mention a few additional things from what we're doing in North Carolina, and I think we'll focus on doing even more going forward. We have a number of initiatives around advanced illness care, advanced directives, everything from reimbursement to training, to engaging care teams, to our foundation that invests in serious illness care. We've got a palliative care advisory group. We've got one of our medical directors in the room who has been key in this work. We've got a number of palliative care pilots. We also have pilots focused on people with serious illness and how we provide care coordination for patients and families with serious illness. I think our challenge moving forward is, to assess the array of care models and efforts we have right now, what's working, what's not working as well, what can we learn from, and then expand that in a way that we deliver on where I started, that we care for every member and customer like they were our family member. I'll share one, not a story that was a learning already. We had a child who I found out we had not been giving them their life-saving medication for their genetic disorder for a month. The good news is our team fixed it in 40 minutes. The other good news is they did an after-action review that was one of the best I've seen in a long time. One of the challenges, though, is we had a customer service rep who spent 80 minutes on the phone and had no way to escalate effectively to resolve this. So one of the things we're going to do is how do we empower our frontline reps to treat every member like they're their family, and they can escalate it appropriately, and the next child or adult with serious illness, has a better care experience. And I will say, having interacted with the folks in North Carolina, CMS is actually a mission-driven organization. The people working there are mission-driven. I hope you know that. Moving to North Carolina, it's a very mission-driven organization, and the workforce is passionate about care for the people we serve. Actually, I'm going to cede some of my time to my colleagues, so I'll just end with, even though I was told to fill my entire time, I'm not going to do it. Sorry. I'll end with a story, and this one will say, a few of you have probably heard this one, me tell you this story as well. I am still a practicing physician, as it was said. I care for mainly children with multiple chronic conditions and their family. The majority of them are on Medicaid. I will be doing that at UNC Children's. I will also be getting a faculty appointment at Duke, because apparently I'm not supposed to choose. Maybe I need to get one at NC State too. I'll be working for free, so there's no conflict of interest. And I did get my medical license, which was incredibly painful, just like the last 6 times, to fill out all the forms. I had the pleasure of caring for a 13-year-old who had multiple chronic conditions, and conditions that she was never going to recover from and were progressive. Her mother, the first time we talked about this, actually the sign out was unfortunately a sign out you often get from hospital medicine docs, and I love hospital medicine. There's great ones, hospital medicine docs as well. My sign out was, probably somebody should talk to this family about goals of care, but you're just here for the weekend. I was only here for a week. sign it out to the next person. And I was like, yeah, okay, that's not exactly what I'm going to do. So we had a very difficult conversation over the course of a weekend. I actually took care of this mother and child for multiple weekends. And then unfortunately, as it happens with hospital medicine sometimes, at some point I was like, wow, I haven't seen them in a really long time. I wonder what happened. And then I actually planned, I'm going to look it up. When I go to next time I'm in the hospital, I'll look it up on the electronic health record. But before I can do that, literally walking around CMS one day, I run into this person and she says, do you remember me? I say, well, of course I remember you. And she said, you know, I was in a different part of the federal government. I transferred to work with you. And the reason is, like, you changed the course of my family's life because of that discussion. So I think you all that do this each and every day know this. This isn't about me. There's tons of people in this room that are way better at this than me, to be clear. But I think it's at least getting a level of training, education, focus that our care teams can deliver the type of care that we would want for any of our family members. And I think most important is when, certainly at end of life, but also once you have serious illness, that's what you need. That's what we would each want for the people that we love in our lives. And so with that, I will actually stop. I'm not going to do big intros like I said I would. I'm going to let you do a short intro on yourself. We'll go down the line, and then I think we'll have plenty of time for questions and discussion.